All yours to go. So
Thank
I
you.
can't give you the presenter mode, but just let me know when you want me to go forward. All right, start with there, no? Okay.
Perfect. Thank you so much. Sorry about that, everyone. I'm going to be doing a bit of a, what's his name? Matt Hancock, and asking for a next slide, please, after every time I say something. But this is a very interesting case that I wanted to share with you all from a little while ago. Obviously, confidentiality is going to be obtained throughout the entire process, and that's specifically important with this case. So just bear that in mind. So this is maternal history here. This is a 19-year-old woman who is a Gravida 1 paranaut with a medical history of being asthmatic on inhalers that she takes salbutamol for, and a BMI of 44. She is A positive with virology and SCAT NAD, and her glucose tolerance test was performed at 28 weeks and was normal. Before 16 weeks, she had a PV bleed 5 times, which she was admitted for A&E for. So there's lots of concerns sort of earlier on in her pregnancy. And if you go to the next slide, we'll see that they actually do continue. So at 19 weeks, PV bleed, which she was discharged for. At 22 weeks, another PV bleed of approximately 50 mils, and she was therefore admitted. Discharged after 24 hours of no bleeding. No idea really where the bleeding was coming from per se, but she had follow-up scans and whatnot, but to ensure that it wasn't an issue with the placenta. Reduced fetal movements for 3 days at 29 weeks with abdo pain. FFN was 4. They recommended admission again, but she declined. 29 plus 3, ultrasound was normal fetal growth, fluid and Dopplers. Abdo pain again at 32 plus 2. She was admitted for pain management. OS was closed. 34 plus 5, ultrasound showed oblique lie, but normal growth, Lycors and Dopplers. Another episode of abdo pain later on that day, which she was then discharged for. 36 weeks, had a follow-up scan for her BMI. Normal fetal growth, Lycor and Dopplers with an estimated fetal weight on the 34th centile. 38 weeks, she was query PROM. She'd reported some leaking for about 3 days, I think, but ROM plus was negative and no obvious signs of Schwann from speculum. She had some raised blood pressure at the time. I think it was around 149/90. So they gave her a stat labetalol, I believe, and PET bloods were sent and normal. Booked for DAU follow-up, but never turned up. Her PCR at the time was 29. There was a little bit of miscommunication routinely, I think, at Croydon. Correct me if I'm wrong, to those that know the guideline better than me. But for our women that have raised BMIs like 44, we would routinely recommend induction before 41 plus 5. But her case midwife had booked her in for 41 plus 5. So yeah. We go to the next slide. She came in at 41 plus 2. She came into triage with reduced fetal movements, and at the time she was contracting 2 in 10. She reported that she was, she'd questioned whether or not her waters had broken, but it wasn't obvious from the pad or speculum that was performed in triage. At 06:30, her cervix was found to be 2 centimetres dilated, and the plan was for induction of labour. So CTG, this is her initial antenatal CTG. All the previous ones from her abdo pain were all completely normal, and the baseline sort of decreased over her gestational period, so as we would expect. So as you can see here, baseline sitting at around 130, 135. We've got some accelerations present, no decels, and some good variability. I think there was probably some issues here with the what's it called, the CTG itself, just because it is very faint. If this does happen, please do make sure that we have an adjustment of the fetal monitoring and or get a new CTG, just so we can better interpret it when it's clearer. Any questions at this point, anyone? No? Okay, we'll move on.
Sorry, just what's the plan? Admit or?
Yeah, plans to admit.
What events?
Plans to admit and induce. At the moment. But because she was contracting, they didn't want to give a pessary. So I think, and because they were sort of picking up at the time, I think the general gist was, let's admit her to Hope Ward, see how we get on, re-examine her a bit later on, see if the contractions pick up or die down, and then hopefully to be ARM'd on labour ward, which is pretty much what happened. At 6 p.m, she was found to be 3 centimetres dilated with bulging membranes. So the plan was just to await an ARM on labour ward when a bed space became available. And luckily, this lady didn't have to wait for too long, because at 20:50 she was then transferred over. CTG was commenced. I think I've accidentally missed out the first sort of hour of trace here. But this was her initial CTG when she came onto labour ward. She'd been quite urinary retentive during the day, so the registrar recommended an indwelling catheter. Re-examined her and found her to be 4 centimetres dilated. I believe the presenting part was -1 at this point, and no membranes were felt, which is quite a significant difference from the 3 centimetres with bulging membranes she was before. There was a bit of query around this case as to whether or not we properly detected that she'd SHROM, just because it was the VEs were very different each time that she was examined. But are we still happy with the CTG?
Yes.
Yeah, happy to continue.
Amazing. So if we can go to the next slide. Okay, so as you can see, she's got some raised blood pressure here, 158/104. She's also very tachycardic and tachyapneic as well, but temperature was normal. So the plan was to start some Hartmann's, which was started at 22:30, and then see how we get on. Any recommendations?
I would normally always ask why fluids. Why do we think she's tachycardic and hypertensive?
I think because she'd been quite urinary retentive, I don't think she'd had much to drink in the day, and that's, I think, what the sort of reason for fluids was at this point, was more for a hydration aspect as opposed to anything else.
Okay.
Okay, can we go to the next slide? Oh, we have. So it's obviously continued. There's multiple loss of contact. I think this lady was quite difficult to monitor just due to her BMI. At 2300, she had a urine dip. Leukocytes was, 2 pluses of leukocytes, 2 pluses of ketones, and 2 pluses of protein. So PCR was sent as well. And we got the results back within the hour, which we'll see on the next slide. Any recommendations for what we want to do here? Any sort of interpretation?
Do you want to put an FSC on, maybe, if we're difficult to monitor?
Yeah, that was my thought when I first saw this. But also we need to adjust the TOCO a little bit, because at the moment it looks like she's just having one very, very, very long contraction, and it doesn't appear that she's getting much resting tone. So definitely something to consider whenever you're looking after women in labour. Please do mention the resting tone when you're palpating in between those contractions, and adjust the TOCO as much as you can, really. But from what we can interpret from the trace, it looks like there's a possibility for some variable D cells there, but our baselines remain pretty stable with some variability that appears to be good, although difficult to interpret because of the the amount of loss of contact, essentially. Can we go to the next slide? This was the point where we were questioning whether or not she'd actually SHROM more than 24 hours ago. Although it's not part of our protocol at Croydon to give antibiotics once 24 hours prom, I think due to the fact that she had maternal tachycardia and tachyapnea, it was recommended as well, and Kefenmet was given. And then at 23:30, this lady requested an epidural, so she was sat upright for this. If we've got difficulty monitoring women before they have an epidural, the likelihood is that we're going to have some difficulty during. So please just always consider putting on an FSC if you think that you're not going to be able to maintain contact. Any comments on the CTG?
Can anyone see cycling? Because I struggle.
No.
Right, so absent.
Yeah. And there is also there is gaps that is and the variability. If I'm getting all the time, it's reduced as well. In addition to the cycling, yeah.
So what are we going to do about it?
I would say at least an FSC and scalp stimulation will show us something.
Yeah. We're going to go to the next slide. So at this point, IV paracetamol was given, and her epidural test dose was given at 23:53, and at midnight on the dot, the CTG was classified as normal with no hypoxia. Anybody agree or disagree with that?
Disagree. You can't really interpret. There's so much loss of contact.
Yeah. That is something that you'll see a little bit more of as the sort of time goes on overnight, with the fresh eyes monitoring and the hourly reviews and whatnot, is that I think there was some difficulty with interpretation in this case, but you'll see that as we sort of continue further. Dagmar, if you're happy to go to the next slide.
And also with a pulse of 113 and 121, I'm slightly, like we are having like choreo. Yes, there is no temperature yet, but we are thinking if we put 1 + 1, there is a possibility of 24 hours. There is a possibility of choreo. There is the pulse. And if I want to interpret really that fetal heart has not gone up or has gone up but came down like 140 for a tachycardic patient who will be pyrexial soon, I don't know. It doesn't add up much, except that we need to be very vigilant. Yeah.
Absolutely. Can you go to the next slide, please, Dagmar? Okay, so our PCR result came back and was actually 62, and in combination with her blood pressure, obviously this could be very well pain related at this sort of stage of labour, and obviously contaminated by the fact that we think that she may actually have broken her waters. Bit difficult to fully determine, but something definitely to consider when we're going further in this case. Also, the fact that she's had so many episodes of abdominal pain and PV bleeding in pregnancy, all of these sorts of things were sort of adding up in my mind and thinking, okay, there's a possibility here that there's something that may not have been identified clearly during her pregnancy that's now bringing itself to light when she's in labour.
She has a catheter though, so if this was a kind of catheter sample, then regardless of when she ruptured her membranes, this PCR should actually identify proteinuria. I mean, I'm aware of the kind of debate, how reliable is it in labor, but 60 and above is actually quite marked. And if this was indeed a catheter urine sample, then I would treat her as preeclamptic with potentially reduced placental reserves.
Yeah, that's such a good point. Although she wasn't medicated for her blood pressure at all in pregnancy, and as far as I'm aware, she wasn't medicated for her blood pressures being raised in labour either. So we continue. Bearing in mind our baseline was sort of 135, 140 when we started. Obviously, we've not got that sort of technical raising baseline at the moment, but as Dagmar was saying, we're still not seeing any cycling. So this baby's possibly getting to the, possibly telling us that actually they're not very well, because we're not getting that interaction between the sympathetic and the parasympathetic nervous system. They're not going through these sleep cycles. Baby's actually very much reserved. An FSC was placed at 0,020, and the cervix at this point was found to be 5 centimeters dilated. Can you go to the next slide, Dagmar? So blood pressure's come down slightly to 136/92, and the pulse is reduced down to 108. An epidural top-up was given at 0100, and Synto was started at 0105. Would anybody else wanted to have started Synto on this lady?
It's not very obvious as well, the contractions. It is like an irritable uterus, right? So it's not really showing. So what did they mention about palpation? Anything?
No.
And with variability, I feel like we are more than, I don't know, maybe 60, 70 minutes of no variability, or the reduced variability, and no cycling. So
I'll just go once back to regarding timing of variability. Sorry. I do not know what happened here. That might be the FSE application, so because it's 23, so that's the baby showing a response. And other than that, that's the variability. And one more back just for Mr. Naguib.
yeah, so we are, Dagmar, we are really about 90 minutes, isn't it, or what? Every one of those is 10. This is 30. Then the one you put backwards is 30 or more, and then more. Yeah,
We have
we are.
contact and can't comment upon it, but so we definitely
Yeah.
can't see any cycling. So
No. Yeah.
Yeah.
Okay.
Back
Yeah.
to Maria. Does Croydon start Synto on suspected choreo?
With acceleration, with cycling, yes. We give a short trial.
It's just because you're in nighttime, you have a BMI of 44,
Yeah.
and it's 1 o'clock and you're starting Synto.
Yeah, so similar to again, maybe same school as George's, as Austin was usually teaching us. Really, it is a short trial of Synto, and like not a short meaning that we are not going up with the regular interval, but being 5 centimeter BMI 44, you balance the risks and benefit. And if there is good cycling, if there is good variability, yes. In this case, I wouldn't have, no.
We're not really getting many reassuring signs before we're starting something that's actually going to stress the baby out further, are we? Which you wouldn't,
Exactly. Yeah.
Which you wouldn't necessarily want this case.
Yeah, I would like to start Synto on a near normal or normal CTG, kind of, but here we have got a nervous system that is slightly blunted by the infection or by choreo, which is manifested. So I would be slightly more conservative in starting an agent like Synto. No.
Thank you. Can we have the next slide, Dagmar? Okay. So blood pressure's gone up again, and now her pulse is 115. Still remains with tachyapnea as well. Resps of 20. Nifedipine 10 milligrams was given, and I believe actually that pre-meds were given by the midwife, because at this point the midwife was on, I think this was the break relieving midwife, had concerns with the CTG here, and there was possible talk of going to theatre just because of the amount of reduced variability. But we continue. So it remains very similar for quite a prolonged period of time. Epidural was recited at 140, and obviously Synto's been stopped for it to be recited, just so that it gives the woman a bit of a break. Blood pressure's come down a little bit since the nifedipine. Pulse still remains quite high, and the CTG again is classified as normal with no evidence of hypoxia.
I think I agree that there's no evidence of hypoxia, but there is still signs of infection. So I think we have to be careful with how we classify it, because it can be sort of, you're focusing so much on the hypoxia, you're not looking at that whole thing of the picture. So that might be why they're classifying as normal. Plus that human factors of 2 a.m.
Yeah, absolutely. We're midway through the shift at this point, and that's definitely going to be contributing, specifically not knowing what's been going on in the day for those people as well. But we shall continue. So at 02:25, Synto is then recommenced again at 3 mils per hour. Blood pressure's come down, more so probably likely from the epidural working slightly better now. Maternal pulse remains 112. And the pulse oximeter, as you can sort of see at 2:30, is put back on again, so we can definitely clarify the difference between maternal and fetal heart rate. Difficult because of the TOCO to determine what's going on with the concordance between contractions and decelerations here, but we can clearly see that baby is starting to show us some further signs of concern. At 02:58, she's moved to left lateral, following the sort of downward decel that you've got here. But the plan is to keep the Synto on at 3 mils per hour. Blood pressure remains normal, and pulse looks like it's coming down slightly, but the CTG is still classified as normal with no evidence of hypoxia. Again, very, very difficult to determine or interpret this trace, purely because this TOCO is either not picking up any contractions because there aren't any, or because it's not been placed well on the abdomen. Obviously, there's going to be difficulty with this woman's quite raised BMI, but that would really help us to interpret these things better. It looks like the one towards the end, so at that 0302 mark as well, this looks very chemoreceptor in the way that it takes quite a substantial amount of time to return back to its baseline as well, and almost pencil tip variability within that deceleration too. Unfortunately lost a bit of contact, but from where you see the sort of peak of it at the bottom, or the trough, sorry, this baby's sort of, to me, telling me that they're not very happy, and that they're becoming significantly more distressed. Can we go to the next slide? Synto is then increased at 03:30 to 6 mils an hour, and women's blood pressure started to come back up again, with her pulse remaining at 100. Anybody want to change the plan up at all?
I would like to examine, if possible, and see the progress. I don't know when was the last one.
When they put the FSC on, I think it was around midnight, 1 o'clock, and she was 5 centimeters.
Yes, sorry, I'm not familiar enough with the slides to find that fast. I think it was here, FSE 0020. And now I have to go back to the kind of CTG that we're on. Bear with me. I think we were here. No? Oh, one further. No hypoxia, and you said you were starting to be unhappy, and here's the central increase. So it has been on 5 o'clock, 0020, 5 centimeters.
So we're now 3 hours post.
Yeah.
Is there anything that
Yeah.
you're...
It hasn't changed dramatically, so I am okay to continue another half an hour till the next examination, really.
Okay, perfect. Yeah, so if we go to the next slide. So at 03:45, CTG is classified as normal with no evidence of hypoxia. Blood pressure looks like it's starting to stabilize, but she's still tachycardic, and her temperature's now gone up to 37, although not a fever, has gone up since the last time we measured here. What I found interesting about this specific slide, is the fact that our baseline appears to have reduced. And although that's quite common when you see babies that are in more sort of state of quiescence, if you like, the fact that we've been sat at 135, 140 and with reduced variability, I just found quite interesting that it's actually reduced, and at some points it's actually down to about 110. Difficulty to sort of determine whether or not this is deceleration or if this is actually in fact a baseline. And to me this looks, tell me if anybody disagrees, but to me this looks slightly more wandering.
On this particular slide, I would have difficulties, but I would always essentially kind of spread it out. And here it does not look wandering. So it's on this, yes. But if you essentially, you can't go forward in time, but you can go back. And if I would essentially kind of spread that out, or essentially kind of, I do not know what the kind of Croydon monitoring is like, but many of the kind of central monitors have an overview underneath. So it's the kind of actual patient slide and then the overview, which kind of puts about 2 hours together. And that is quite helpful because it makes it very often more agreeable to agree upon a base rate, yes or no, because on these 30 minutes, I would find it more challenging. But the other thing is you can have an infected mother or you can have an infected baby. So, and it's the inflammatory response of the mother that then, if it's not a choreo, if it's not the membranes that were infected, that essentially kind of shows the responses of the baby. And you've given antibiotics, paracetamol and fluids, no? And the maternal heart rate is not brilliant, but has come down. Her blood pressure is better controlled, and she, with the kind of nifedipine. So it's just that this baby is not cycling. So the question is she making progress? Because otherwise you're out. So I would at the moment just really like to see the next VE and keep an eye on the base rate and variability.
Thank you. If you go to the next slide, I think that there's a VE definitely coming up. So Synto's increased now to 12. CTG still classified as normal with no evidence of hypoxia. And we continue. Blood pressure stable, pulse is still 110. We've even gone further. Still not really any evidence of cycling. CTG still classified as normal with no evidence of hypoxia.
Lots of uterine activity.
Yeah.
Mm-hmm.
So the TOCO is clearly picking up something. You could argue that she looks like she's contracting sort of 5 to possibly 6 in 10 if you look at it very, very carefully. But what I'm more concerned about is the fact that actually when it comes to things like hyperstimulation, tachysystole, it's not necessarily about how many contractions you're having within a 10-minute time period, but actually how much resting tone is she getting. We sort of, I would say, arguing more towards, okay, have we got placental insufficiency? Because we're still not getting any cycling for this baby, and now the uterus doesn't appear to be having any break in between contractions as well. So how's this going to be affecting our fetus?
But variability is slightly, I would say, better. Yeah.
Interesting, because I was just kind of hitting that out there because it's a sign of infection, so uterine activity. So whenever you have a lot of uterine infection, it's a question: too much Synto, infection, or rupture. No, these are the three things that I have in the first instance in my mind. But yeah, it's now 5:30. It's 5 hours after starting Synto. So it's just about the VE, really. Yeah.
Yeah, I think the plan, I'm just thinking back, I think the plan made was to wait 6 hours after Synto before re-examining. So hopefully, here we go. Sorry, Mr. Nikki, did you want to
No,
say
no, no. I mean, it doesn't make sense to me. You know, like if you are starting from 0, 1, 2, yes, I understand, because you are in the latent phase, kind of, and you want to wait 6 hours till she's contracting, but she was 5.
Yeah.
So she was in the active labor to wait 6 hours, you know, like, I don't know where is the, yeah, I mean, I must admit, I can't really put it into any kind of rationalization, but yeah, whatever happened, happened. So yeah, fine. So in 6 hours, oh, no, in 5 hours, we got from 5 to 8.
Yeah, so sort of routine progress for a primate, presenting parts.
Yeah.
Synto, I think at this point was reduced down to 12 mils per hour. CTG at 6 a.m. was classified as normal with no evidence of hypoxia.
Out of interest, I don't also understand the rationale of reducing the Synto when you have said the CTG is normal. So, I mean, it's one or another. It doesn't follow a pattern here. Like, you reduce the Synto because you are concerned about the CTG, or because of, you know, I don't know. Yeah.
They might have done that because they saw also lots of uterine activity in the kind of first one. And it is that on the VE, I assume that this here was the VE where the arrow is, but that then this is 1, 2, 3, 4, potentially 5. But you know, it's difficult to count. But maybe they had the impression that there were too many contractions. I'm just trying to find a reason. But yeah, I'm
Yeah.
with otherwise. Yeah.
Hey Dagmar, it's Mamuna. Thank you. So Nagib, I was going to just, I think, echo what Dagmar was saying, because when you look at the uterine activity, I wasn't there, but I would also think it would be very likely due to uterine activities.
Yes, but in this context here, Mamuna, you know, although I can see what they are thinking or what Dagmar is saying, but what I'm thinking is, if CTG is maintaining and the contractions or whatever we are seeing on the lower side has not really changed for the last 4 hours, it's all erratic. It's not that it has become something different. If you go about 10 slides before, they are similar to what we are seeing. And we were on 3, but we increased. And now that we are seeing it is still the same, we are decreasing. You know what I mean? It doesn't follow a rationale that I can follow in a way. But yeah, fine, okay. In a way, we have reached some sort of reason, if we can, of the reduction of scent.
Just a quick question. What was the Lycor being monitored at? Was it clear? Was it offensive? Anything blood stained? Anything noted?
Not really, no. I think there was one piece of documentation that said the Lycor was clear in the entire series of written notes. But because there was still question, I think this woman was never ARM'd. So she came in query Schrom, was confirmed not to have Schrom. Then she was examined on our antenatal ward and there was found to be bulging membranes. And then she was re-examined again when she joined labour ward, was examined, and there was no membrane spelt. So somewhere in the space of 2 hours, she shrum, but it wasn't really detected. But there's very, very limited documentation as to what kind of liquor was seen appearing, other than maybe one instance where it was said to be clear.
Okay, thank you. This part of the CTG, if we were just looking at this last half an hour, I can see why they said normal. You've got an acceleration there. You have got shouldering with that deceleration. You've got good variability. But in the scheme of things, and looking back on their previous trace, obviously, that we've reviewed, I would be concerned. Also, with our history of PV bleeding and sort of a little bit of irritable uterus here as well, are we potentially thinking some sort of, I don't want to say it, but some sort of abruption or something? We sort of have to look at all of the aspects of her antenatal history, her previous CTGs, the CTG now. I'm not saying she's having one, I'm just saying.
No, but it's something to be aware of.
Yeah.
But also the fact that she's, you know, that we've had fetal and, well, we had maternal tachycardia for quite a significant amount of time as well, saying, and alongside this uterine irritability could indicate an infection within the mother. And at the moment, we're not really passing this down to the fetus because we haven't necessarily seen any signs, well, any baseline rise, but that's not always the only reason for,
I think that
there was an issue.
Completely agree with you. Also, I think with someone who's got BMI 44, it's just being aware as well. What was her resting sort of respiratory rate when she wasn't in pain? Because I know larger BMIs, we know they can have a higher respiratory rate, they could have a higher sitting pulse rate. Is this normal for her? This, you know, being aware of that sort of her sort of comorbidity of having large BMI anyway. It could be something to be aware of. So when we're looking after these women, we shouldn't be classifying them as that normal because their resting may be higher because of that large BMI. I could be completely wrong here, but it could be something to consider.
No, I totally agree. The difficulty we have, obviously, is the fact that in every antenatal appointment, we don't routinely do a respiration rate. So it wouldn't be something that we would sort of have down as something to look back on, you know?
Of course, yeah. Thank you.
Perfect.
I mean, in the bigger scheme of events, if I am here and I'm assessing the case from the risk point of view and the decision to continue, I would say still in the okay zone, is not in the dangerous zone because it is stable baseline and variability is better. And yes, so yes, we are choreo, yes, we are looking, but maybe in the bigger scheme, I wouldn't have reduced the Cinto, but yes.
Perfect. Thank you. Can we go to the next slide? Okay. So blood pressure's returned to normal, pulse still remains raised, and CTG is classified as normal here as well. Anyone want to comment on this one?
Yeah, in this one, I wouldn't have said normal, you know, like there is a definite chemoreceptor going on like the waves here very nicely when you look at again transversely rather than you know, quick look. There is chemoreceptor, so yeah.
Yeah, I this was the point where I started to think, okay, what is this baby trying to tell us? And if you go to the next slide, Dagmar, we sort of continue here as well. So these sort of chemoreceptor decelerations that actually, if we're now considering the baseline to be 135, 140, looks like we're possibly getting a small rise, but not necessarily enough to consider a significant increase. These decelerations are lasting for longer amounts of time and also having some baroreceptors in between them as well, possible short, sharp variable decelerations as well in between. We go to the next slide. So although not enough to sort of consider a more than 10% increase in baseline per se. There have been periods of time where the baseline's been sat more at 120 as opposed to 130, so could be significant enough. I think the maternal pulse was doubling here, which is why it looks like she's got a pulse of over 200, but actually manually at this point it was 111. We continue. CTG classified again as normal with no evidence of hypoxia. Two significant enough chemoreceptor decelerations there if we think actually doesn't really return to baseline here for about 7 minutes. You can see this baby's trying to return back up, but actually not being very successful with that. Dinto is still running. At this point, I don't know if anybody would agree with me, but I personally would have stopped it.
I would have liked to continue for another 5-10 minutes to see if this is a repetitive one.
Will you go to the next slide? So maternal position changed due to variability at 8:15. There was an occlusion, I think, within the epidural. So the anaesthetist came to review that at 8:25, and then it was returned to normal again. And as you can see, we've now got quite a significant baseline increase to around 150.
I think just putting ourselves in the position of that midwife, I think we're being reassured by what looks like an acceleration, but necessarily isn't because of what's happening in the uterine activity. So I think we have to remember, obviously, signs of infection with the fetus, and if she is having contractions and you're having sort of an acceleration with the contraction, not necessarily thinking that it's maternal heart rate, but actually thinking that could be a sign of the CNS. So I think what could be, when you're looking back on that last slide and then you've got what looks like accelerations in the trace, I think, do you know what I mean? I don't think we're being falsely reassured here that actually it could be signs or it could be an overshoot potentially in that sort of 7:45 bit. I think that could be, when you look at it from a distance, oh, it's just an acceleration, baby's fine. So I think we have to take that whole clinical picture into account again. And also if you think handover as well, 8 o'clock, what we're sort of looking at in regards to human factors as well.
I think you can kind of see here, although, yeah, like exactly what you're saying, it looks like accelerations. Actually, if you look at the small dip you're getting before it goes up to that acceleration, I would argue that these are actually overshoots, and also arguably late as well, because if you go at 07:45, by the time the contraction has sort of got to its point, that looks like where it dips. So yeah, I definitely wouldn't consider these ones accelerations, but totally get the fact that at this time in the morning, human factors are a massive element, and we're all going to be waiting for that midwife to come over and hand over so we can go home to bed.
Just a little definition. Accelerations by definition start from the base rate and we go back to the base rate. So this one is no acceleration. Just to clarify, this here, sorry, the arrow, this one here is no acceleration. Yes, because it does not start from a normal base rate and return to a normal base rate. It doesn't.
Yeah, I completely agree. I think it's just looking from afar what people could potentially look. If that was on the central monitoring and you glanced at it, I think sometimes that can be where we can go wrong in regards to acceleration, especially in labour as well.
I think that happens a lot more frequently than we would like to think as well, because it's very easy to look at things from a distance, which is why when we're doing a fresh eyes assessment, we shouldn't be doing them from outside the room, looking at the central monitoring and just looking at it full at glance and saying, oh, that's normal. Actually going into the room, gaining the full clinical picture and assessing things from sort of start to finish properly is so important. But we still
Yeah.
see it.
Anyhow, we're a slide further. We're here, position change, variability, and anaesthetist because of the occlusion. And we're having a base rate of 150 here at the end.
Thank you, Dagmar. I'm aware of the time, guys, so we're not far away from the end now. If you're happy to go to the next slide.
Yep.
So the more IV antibiotics are given at 8:40. So I believe it's now been around 10 hours since the last dose were given. The CTG has been classified as suspicious with a gradually evolving hypoxia by the day midwife that's come on. Do we agree?
It is gradually evolving, so definitely fine. Yeah.
Perfect. Can we go to the next slide? So again here, we're not picking up on the again, same definite increase in baseline. We've got chemoreceptor decelerations. Synto is still running.
Variability
is very reduced.
So what would you do?
Turn off the Synto completely. And see if the position change makes a difference at all, although quite unlikely with this kind of event now, specifically after sustaining it for this prolonged period of time. Re-examine and possibly discuss the option of having a cesarean section.
Yeah, so she had the last VE at 5:40.
Yeah, and the next two, I think they were waiting for the registrar to come for a ward round to do that examination. Be coming up if you go to the next slide. So at 9:30, the doctors come in and do ward round. CTG is classified on the obstetric review as gradually evolving hypoxia, and FSC is reconnected. As you can see, it kind of goes off here when she's being examined, most likely also due to a position change. But she's found to be fully dilated. So I think, and this was, sorry, presenting part was at spines. Epidural top up at 9:45. Baseline looks like it's kind of reduced down from where it was raised previously. However, our variability is significantly decreased still, and it's been going on now for a little while. But the plan was to give her, good couple of hours. The plan was to give her some time for some descent before starting pushing. We go to the next slide. So pre-meds were given at 10:10 and a second cannula was cited just due to, I think, the risk factor of having a postpartum hemorrhage. Her blood pressure, as you can see, is now gone up again to 151/90 with a pulse of 117 now. Difficulty determining this baseline here, considering we've gone from the beginning, it was sort of sat at 130. Then we have seen an increase and it looks like it's come down again, although arguably you could say that these are chemoreceptor decelerations from the time that you can argue that these are chemoreceptor decelerations from the amount of time it spends below the baseline. At 10:25 she is involuntary pushing. I don't think her epidural was working particularly well, so she was re-examined by the midwife, remained fully dilated at spines, and active pushing was started as mum was feeling the sensation.
So the last slide there, Cara, when at the end of it, my concern here that we are falsely reassured that everything is settling down, and we went from 150 now to 130 to
120 almost.
110 actually. It is crossing with the mother, so it's 110.
Yeah.
So we were 150, now we are 110 while pushing. And if we are thinking carefully, this is not a baby that is getting better. This is the true classification of a bradycardia, because when we talk about brady, you know, like saying so and running, it is a prolonged deceleration more than 3 minutes. But this is the bradycardia, where the baby is brady and gone to 110, and I think in the next slide it will continue on 110 or 100 now.
So you're saying you're having a vegetative nervous system instability because so that you can't define the base rate here, and or it seems to be kind of getting lower. Is that what you're saying?
I don't think
I'm thinking that there is heart failure at the moment, so or sudden heart failure, kind of, that is going from 150 to 100 now.
That would be the letter of death. It doesn't look like that,
Yeah.
but I do agree that we have a central nervous system kind of difficulty here, yeah, and that can also show informal.
Yeah, then with the next one, Dagmar, you will see that came as a glance. Also the central nervous system is just going off, and the heart is going off. Everything is going off because now we are definitely on 100, and I'm not sure why we are not intervening. You know, like we intervene so well when it is 140 going to an 80. But we didn't intervene at all for a 130 going to 110, 100, yes.
Do you have in Croydon anything that tells you that hypervariability is a sign of instability and sickness? Yeah, okay, right.
Yeah, we talk about it all the time. The kind of saltatory, kind of instability that reaches this situation here is deadly.
All right, so I assume that an escalation has found place, hence the reg is present.
The reg was not called. The reg came because of the CTG being like.
Okay.
But we are now nearly 25 minutes into the bradycardia.
Yeah.
Yeah.
Well, actually, more than that, because this is 30 minutes and it was 5 minutes before we started.
Yeah.
This. So this baby needs to be delivered. If you go to the next slide. So it's now, sorry, Dagmar, do you mind going back one? Sorry. So our deceleration or our bradycardia started at around 10:22. And then if you go to the next slide.
So two slides back is where we essentially feel the base rate is unstable and going down.
Yeah.
And we have essentially the kind of hypervariability. Yeah. So it's essentially always in half an hour, isn't it? Mm-hmm.
Yeah. So it's now been this slide alone. This now 32 minutes of a bradycardia. The decision was made for an instrumental 35 minutes after the initial drop in fetal heart rate. Their baby is direct to OA and at spine, so decision is made for forceps. At 11:15, the right blade is applied. The left blade, unfortunately, didn't lock. So the consultant came in and performed a very quick Kiwi delivery. The woman then had a shoulder dystocia that was diagnosed at 11:22. And at 11:23, this baby was delivered. This baby was delivered about an hour after the fetal heart rate had dropped.
What was the maternal heart rate the whole way going through this? Is it documented?
It remained from what I can tell from the Cerner record around 100.
So we could potentially be picking up some maternal maybe at some point.
Yeah, although the FSC
is FSC.
Yeah, there's research in regards to FSC and it when there's sort of a bradycardia and picking up maternal heart rate if it is sort of a stressful situation. There's some research. I'll send it over to you. But yeah, okay, fine. Thank you.
Yeah, but this is usually, Sorsha, if you are putting the FSC initially and picking up the maternal initially, yes, you can have it from the beginning. But this FSC was picking up very well the baby from the beginning. So I'm not beginning, I mean from the middle. So it is baby.
Right. So the big question is obviously the outcome. Yeah, can I just go about 5 slides back? So it's essentially 1, 2, 3, 4, right? Before I ask, or Cara is asking, what do you think is the outcome? The reason why I did that is because I can't see much deceleration. So do you think hypoxia is the kind of problem of the baby?
Anybody wants to guess?
I think, are we guessing the APGARs and the gases?
Mm-hmm.
I missed it. I think gases will probably be abnormal. The arterial, potentially 7.0 something. And venous, because we've been going on for a long time, I think venous will be quite poor as well. Basic excess will be high. Yeah, lactate will be high. I don't know. APGARs, I think this baby with the shoulder dystocia as well. I don't know what manoeuvres they did, but potentially that could cause some poor APGARs, potentially attempt for resus maybe. So I think poor gases and poor APGARs.
Well, although from head delivery to baby delivery, you have 2 minutes regarding shoulder dystocia, so you haven't got any long period of time.
I'm pretty sure McRobert and
this baby's got, even if it's just 2 minutes of further stress on this fetus is like starting further stress on this baby. So yes, 2 minutes, but actually added stress, isn't it? Sorry, McRoberts.
McRoberts and suprapubic pressure was what I believe was the 2 manoeuvres used to deliver the baby.
Okay. It'd be good, interesting to know if it's a large baby, because they said on the 34th centile, didn't they, 36 weeks.
Yeah.
And they say some babies that are all sort of on the lower end of normal tend to have higher risk of being growth restricted, maybe, or yeah. So if it's a larger baby, or if it's the fact that that might have played an impact on this fetus and how it was coping in labour. I could be completely wrong. Anyone else got any guesses? APGARs 10, 10, and 10? I don't know.
So we're saying that we're kind of having an unstable base rate here, an unstable base rate here, and then I have no idea what I'm looking here at, to be perfectly honest. So if we're kind of saying that we're classifying an unstable base rate, then you then you have, with either infection or kind of hypoxia, a kind of baby that is not going to be a happy one. So I'm just not entirely sure that HIE is leading, or that this is leading, or if this is a predominantly infected baby. But the problem is that you don't need much hypoxia to kind of have a brain injury if you have infection in the background. So I'm saying that I'm not convinced that we're having a significant drop in the kind of arterial gases, because it's not the typical deceleration-based hypoxia. No, so therefore you won't have a terribly much great difference. But if a baby is compensating, then you will have a kind of, then you will also only have a medium extent or degree of kind of base excess. But I do believe that you have a baby that will need resuscitation, and I can't, because of the hypoxia plus, which is not significant, which doesn't look terribly significant, but I think that this baby is exposed to an infection. But the combination of the two is always unpredictable. So do not know. I think this is a baby that needs resuscitation.
Anybody want to guess the APGARs and the gases?
Two, 6, 8.
2,
I've
6.
got- Yeah.
You can reveal it, Cara.
Go for it. Next slide. So this baby's gases were 178. So I think that was an A's. Not far off. The gases were taken within 15 minutes, but the arterial pH was 7.27 with a base excess of -1.8 and a lactate of 6.1, venous of 7.34 with a base excess of 3.3 and a lactate of 5.7. This baby was born in very poor condition and was transferred to SCBU following a set of inflation breaths and 5 sets of ventilation breaths. The repeat gas, which was done within the hour, showed that the gases were 7.1. Sorry, I spelled lactate wrong, and lactate of 10. And this baby was actually treated for HIE grade 3 and was transferred out to St George's for active cooling. Maternal EBL was 3 litres due to tone and trauma at the time as well.
HAE is a diagnosis of either no tone or an MRI. So therefore, what is this kind of diagnosis of HAE grade 2 based upon?
That's based on seizure activity.
Okay.
So
this baby had seizures, yes?
Pardon?
This baby had seizures?
Yeah.
Because it's not written anywhere. Okay, right.
Was there any sign of infection in the fetus, in the baby?
They screened and treated, but as far as I'm aware, there was no blood. The blood cultures were negative, I think.
That's interesting. It'd be good to review the baby in about 6 months to see how that baby's doing.
Baby is still NG tube feeding.
Okay.
It would be also interesting to know the pediatric or the like neonatal resuscitation for the gases to deteriorate an hour later like this. I mean, yes, it's possible as outcome, but as well with APGARs of 1, 7, and 8, and these gases, then the gases to deteriorate is I don't know. Yeah.
It was really confusing for me the fact that the gases were so normal, but they were taken from the placenta around within the first 15 minutes after the baby was delivered. But yeah, just it doesn't really match the overall clinical picture.
But we said about the fact that we weren't worried too much about hypoxia initially during the CTG, but actually that repeat gas could be the fact that if baby used obviously inflation and ventilation breaths, did baby need any further respiratory support? And sometimes if there was any respiratory issues, that could also affect the gas potentially.
This is very true.
Was it intubated? Did they have difficulty intubating? It's a big baby.
I don't think
affect it. No, when they went to SCBU, I don't know.
Yeah, no, they don't. I'm pretty sure the baby wasn't intubated. CPAP, I believe.
ECASP?
Pardon?
Any meconium aspiration potentially?
No, not that it's reported. Okay. All of the meconium, as far as we could see, was actually all behind the baby. Not that would mean that it couldn't have aspirated, but yeah. The other thing, obviously, to note is the fact that she could have actually SHROM 2 weeks prior at 38 weeks, but our tests may have been wrong. So this actually may have been a much longer PROM than we expected. There's no clear definitive sort of time frame where the waters had broken either. So actually determining how long this baby was in that environment, not protected by the bubble, is very limited.
Very nice case, Cara. It is very enlightening. Thank you so much. No, it's very good.
Really puzzling one. I would like to kind of say, was the placenta sent for histology as well?
Yeah.
I would really love to know the outcome because, you know, I think it's more a mix between hypoxia and an infection, and I can't really pinpoint. This is a CTG that I think one is clever in hindsight. Would you mind if I just kind of, I have it because you send it to me and I'm not going to do anything with it, but if I kind of went through it again and yeah.
Of course, go for it.
Okay, cool.
I'll have a look into the placenta for you, Dagmar.
Yeah, because there are a couple of things that at the moment are not really adding up, and that puzzles me.
That's exactly why I printed it, because the further I got into the case, the further I got confused. So the fact that I've had your guys' opinions and whatnot on it has much made it a lot clearer for me as well.
Thank you, Cara.
Yeah, cool.
Thanks, everyone.
Thanks.
Thank you. Thank you, Cara.
Thank you, Cara.